Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, my name is Aseem Sharma, and today we will discuss how we can help detect spontaneous intracranial hypotension, which is a treatable condition that can be debilitating for many patients. I do not have any disclosures. In the next few minutes, we will familiarize ourselves with this disease. We would learn about the clinical scenarios in which we should consider this diagnosis, and we will discuss the imaging findings of spontaneous intracranial hypotension and the underlying basis of these findings. We all know that CSF is normally produced at a rate of approximately half a cc a minute in the choroid plexus, and the homeostasis in the body is maintained by absorption occurring at the same rate in arachnoid granulations and within the neural tissue. In SIH, however, the CSF production cannot match the rate of cumulative CSF loss resulting from either due to a leak in the soft tissues or an accelerated absorption via a fistulous communication directly into the venous system. This produces a CSF hypovolemic state, often accompanied by a reduced CSF opening pressure. Keep in mind, however, that despite the CSF hypovolemia, the opening pressure in many patients may still be within normal limits. SIH patients, just like those with post-LP headaches, often present with orthostatic headache, feeling worse when upright, often accompanied by neck stiffness. Persistent non-orthostatic headaches, however, are not uncommon, and many patients may also complain of tinnitus. In addition, diagnosis of spontaneous intracranial hypotension should also be considered in patients developing spontaneous subdural hematomas. In this 52-year-old male presenting with headache due to right-sided spontaneous subacute subdural hematoma, we also notice evidence for prior bilateral burr holes for evacuation of spontaneous bilateral subdural hematomas in the past. SIH was suspected as the underlying etiology, and further workup documented a CSF venous fistula. Presence of superficial siderosis, as shown here on a gradient echo T2 weighted image, in absence of any other identifiable cause, should prompt a consideration of spontaneous intracranial hypotension. Additionally, some patients with SIH may present with cranial neuropathies, either related to underlying siderosis or possibly related to brain sagging. Dural venous sinus thrombosis, as shown here, affecting superior sagittal sinus on an MRV, can be seen in almost 2% of patients presenting with SIH. A diagnosis of SIH should also be considered in patients being worked up for cognitive decline, especially those being thought of having frontotemporal dementia. This condition, known as frontotemporal brain sagging syndrome, is thought to be related to downward herniation of medial temporal lobes along the tentorial hiatus, as shown here on axial T2 weighted images. In this group of patients, presence of progressive cognitive issues can overshadow any headaches that the patient may be experiencing, and the diagnosis of spontaneous intracranial hypotension may not be clinically apparent. In rare instances, a correct diagnosis of spontaneous intracranial hypotension has been reported to have helped in rapid recovery of comatose patients after epidural blood patch. Brain MRI is usually the modality of choice for confirming the clinical suspicion of SIH. Imaging signs can be divided into two broad categories: brain sagging and reactive changes. CSF hypovolemic state often is associated with downward displacement of posterior fossa structures. Given the conical shape of the posterior fossa, this often results in increasing obliteration of CSF spaces in the caudal portion of the posterior fossa. Downward displacement of cerebellar tonsils is frequently the most noticeable sign of brain sagging. Presence of additional signs, such as flattening of the pons against the clivus, reduced pontomammillary distance, and narrowing of the suprasellar cistern can help differentiate inferiorly placed cerebellar tonsils resulting from SIH from that in the setting of KRE1 malformation. Imaging signs due to reactive changes become easy to understand if we keep in mind Monro-Kelly doctrine that states that due to the rigid, non-compliant nature of intracranial cavity, cumulative volume of its contents, namely brain, meninges, blood, and CSF, will always be constant. So when there is CSF hypovolemia in the setting of spontaneous intracranial hypotension, decreased CSF volume will have to be compensated for by an increase in the blood volume or by some other mechanisms, such as the appearance of subdural fluid collections. Reactive increase in the blood pool is most evident in the form of thickening and enhancement of pachymeninges and dilation of dural venous sinuses. Subdural fluid collections may appear to compensate for decreased CSF volume. Effect of reactive hyperemia can also be apparent in the form of increased size of the pituitary gland. This enlargement can be misinterpreted as pituitary tumor. Careful attention to the presence of other signs of brain sagging and/or reactive changes can help reach the correct conclusion. While the spinal MR is not usually done simply to confirm SIH, reactive hyperemia can sometimes also occur in the spinal epidural space, resulting in enlargement and abnormal enhancement in this region, as shown here on fat-saturated T2-weighted and contrast-enhanced T1-weighted images. These spinal changes can mimic epidural inflammation, and the correct clinical setting in which these changes are observed can help us make the correct diagnosis. To conclude, brain MRI is the modality of choice for diagnosing CSF hypovolemic state resulting from spontaneous intracranial hypotension. Familiarity with common and uncommon clinical presentations can prompt us to look for brain sagging and the reactive changes occurring secondary to SIH that are easy to explain on the basis of Monro-Kelly principle. Our role as radiologists does not end with the diagnosis of SIH. We also play an important role in additional workup that will be needed for detection of the exact underlying cause and its location, something that we will discuss at a later date. Here are some of the references on this topic. Thank you for your attention.